So when you have a sixth nerve palsy, one of the things that you have to do is try and localize where it is. And it's not just for six, it's for all cranial nerves, and really everything in neurology is about localization. Where is the lesion? And then you can figure out why is the lesion. And so every nerve, cranial nerve, has a starting point, a nucleus. So this is the cranial nerve 6 nucleus. So one of the syndromes of the sixth nerve is it could be a nuclear sixth. And the nuclear 6 produces a horizontal gaze palsy because the nucleus of 6 also supplies the contralateral third medial rectus via the medial longitudinal fasciculus, because the sixth nerve nucleus is the final common pathway for horizontal gaze. So if you ding out the nucleus of 6, you get a horizontal gaze palsy. Then you've got the fascicle. The fascicle is that part of the cranial nerve 6 that travels in the parenchyma intraaxially in the brainstem, in this case the pons. And so this fascicle passes by important structures in your brainstem. So it's really hard to get a fascicular sixth or a nuclear sixth without having company traveling with you, like hemiparesis, hemisensory loss, cerebellar signs, because this is a very compact space here in your pons, and it's hard to just get a fascicular sixth. Once it leaves the root exit zone of the pons, then it's trying to go to the eye, and so it leaves the root exit zone of the caudal pons, goes up this bone in the subarachnoid space, and that is called the clivus. So the second syndrome is the fascicle. The third is this peripheral nerve in the clivus. And because this is in the subarachnoid space, increased or decreased intracranial pressure can cause a non-localizing sixth nerve palsy because it's tethered both at the root exit zone of the pons, but also as it's turning into Dorello's canal, it is fixed at that location. So the two fixed points mean you can get a sixth nerve palsy just from ICP changes, either too high or too low. And then once it makes that turn at Dorello's canal, it enters into the substance of the cavernous sinus. So it's in the substance. The other nerves of the cavernous sinus are in the wall, which means they're relatively protected against compressive lesions. Third, fourth, subdivision 1, and posteriorly subdivision 2, as well as the Horner syndrome, which is on the carotid artery. So lesions in the cavernous sinus that are intrinsic to the cavernous sinus often cause isolated sixth nerve palsies because all the other nerves are very far away. And then once it leaves the cavernous sinus, just like all the other entering the orbit nerves, you can pass through the superior orbital fissure to go to its only muscle. Its only job is the ipsilateral lateral rectus muscle. So we've got a nuclear syndrome, a fascicular syndrome, a clival subarachnoid space syndrome, a cavernous sinus syndrome, cavernous sinus, the superior orbital fissure, and in the orbit, the 6 syndromes of the sixth nerve. And you need to look for these things, the traveling company, to try and localize. And it doesn't even have to be localizing. It could be non-localizing sign of increased or decreased intracranial pressure.